Hi, good morning. Welcome to this study club. I'm just really excited about doing this one because Pam was just such a lovely person. So this is my latest newsletter, 81. So thanks very much for joining me this morning. If any of you are going to work very soon and you missed the end of this was recorded and I'll put it onto my YouTube channel for you so you can look at it at any time and just follow this through. As normal, please just stick any questions you might have into the Q&A box too. So now I get most of my referrals from other dentists, and it really is quite a mixed bag. All I do is removable pros, so these patients are primed, ready for that when they come to see me. So this is Pam here. So the referring dentist sent me an OPG, which is so useful. I can actually just check on what's going on with the mouth, really, and it gives me an idea of um, of the state of play. So she's been referred in for a replacement removable partial denture. She has had cancer, and we've had metastases and that type of thing. So she has taken intravenous bisphosphonates. And we know that that really does almost prevent the bone from turning over, and it increases the chances of um, MRONJ, so medication-induced osteonecrosis of the jaw. So in these patients that are sent to me, it's just very, very conservative treatment, trying to avoid any extractions, any sort of surgery, and just replace what's there. So I love to see my patients on Zoom actually to start off with. That's what I normally do. But some of the patients just don't like doing that. And instead, I just do a phone call, and this is free. The Zoom call or the phone call is free and I get on the phone and say, "Oh, hi Pam, what can we do for you?" And she was just lovely on the phone. She was an absolute gem. And she lived about 40 miles from the practice, which is not too far away. Um, she told me that she wanted a new denture. The one that she's got is just sore and uncomfortable, and she does not like the look of it at all. Now, as always with patients, there's a little curveball, and I don't really like this particularly, is being sort of having a deadline. And the deadline was really quite close. So we're talking about 3 months from the point of her ringing up to going away to Australia. And she's going away for quite a long trip to see relatives. And she really wanted a teeth doing for then. So normally I do push back on this and say, oh, well, I just don't want to be pushed into this at all because sometimes doing it quickly can create problems. As we know, when we're dealing with patients, we get it fitted, say, before an important event like Christmas, things can go wrong and not work out as well. Anyway, I got her in and had a look there. So this is how she was at presentation. You can see this is Pam biting together. And this is Pam with her that smiling there with the partial denture, and it just doesn't look great, does it? It's not a superb denture. We've got quite a step between the crowned canine here and that tooth there, like that. Let's have a look in the mouth. So we've got all of this pressure on this front section, and really almost over eruption of these lower front teeth there into that gap there. So there's very little space for a denture if we're going to maintain the patient at that vertical dimension. Now, often when I'm seeing a new patient, I just, when I look through the camera, this is before I make an assessment, I photograph the patient and looking through the lens, the actual viewfinder of the camera, I'm making judgments about what's going on. I'm seeing loads of information. We've got over eruption, we've got sort of splaying of these teeth. It's all it's there's tons of detail there. And also what comes to mind, which is really interesting, is other patients that I've treated who've had similar mouths. And I can refer back to, if you refer back to newsletter 73, this was like Keith's mouth when he came in to see me. His mouth was in an even worse situation, with massive over eruption, dento-alveolar compensation. And I put in a splint there, and it acted almost like a doll appliance too for him. And, that was Keith there. And he'd had a number of acrylic dentures that had broken, and then we'd made him that. So I immediately thought of that straight away. So this is Pam's mouth, top there. I noticed there's a tori. That's not a problem. I will keep the metalwork if we do a metal-based denture out of the way. That's what I'm thinking of. She's got one of these flexible dentures, and I think flexible dentures are like ultimate gum strippers. They're just so bad for the gingivae and also can be quite sore. Some patients do like them, but I just don't offer them as a definitive prosthesis at all. I don't like them. I want to get much better support from the teeth. This is the lower arch. So once I've seen the patient and made a diagnosis, done my pocket probing, charted and everything, I'll then come up with a provisional design. And I do this at the consultation. And I think one of the things that I think is really useful, and this is really hard, is understanding partial denture design. And this is why I've come up with this sequence of all different patterns, arrangements of missing teeth. This document here, which you can download, is really helpful. So Pam's design is very similar to number 12 here, but the numbers of missing teeth are always different, and there's nuances that we need to do. So I drew out this design. So this is my initial design just there. I coloured all of that in, and then I used that as a basis for talking to Pam about the treatment I'm going to do for her. Now, if any of you have looked through this case, you'll see that I've made a error on the design. And what I should have done, let's have a look. If you just look up here, these front teeth across the front there on the denture really need to have metal backings. Or Chris calls them shields. He's my metals technician. So that's really, really, really important part of this to make this robust enough to not break. So anyway, I did that. Now, when I met Pam, she was just such a delightful person, and I got on really well with her. And really importantly, we were totally on the same page. And so I felt I'm okay. I'm okay about pushing this treatment process through because and getting it done before she goes to Australia, just because I've got a good feeling about this in my heart. So if I felt that she was going to be more tricky to manage as a person, then I wouldn't have offered that at all. And I would have said, we'll just make it, and I need that appropriate thinking time. So this is the plan here. Number one, primary impressions. And then from that, I wanted to just do a diagnostic try-in. I wanted to do a little try-in just to arrange, see where we want the teeth to go. That's really importantly. That's really important, particularly because I wanted to change the upper canines, particularly because they were quite dark looking. The porcelain bonded crowns were not nice looking. So I wanted to change those. So the diagnostic try-in was really important to just give us an idea of where we're heading. So once she likes the diagnostic try-in, we can then head on to do the crown preparations, change the crown preparations, and then go through the process of making the metal-based partial denture. So fit the crowns, do a working impression, do a try-in, on a pattern resin to make sure she's totally happy, get the metalwork made, and then finish the denture. I've included my timings too, so I do like to have plenty of time when I'm treating the patient. So this gives you a good idea of what's going on. So I'm just looking at my questions here. There's Toby Edwards Lund. Morning, Finn. I have a patient who presents as a number 17 on your design card. So let's have a look. Massive bone loss anteriorly and only has upper sevens. But I'm worried about doing it because never have. Is that this the sort of case you would be able to mentor me through? So, Tobe, this one here, absolutely, yeah, we can do that. We can do a mentoring session, and I can help you with that. And it's a very, very successful prosthesis, is that, um, Toby. So yeah, so just ping me an email, and we can just set up a session for that. So let's move through. So. Right, so let's go to primary impressions. Let's jump into that. So my primary impressions, I'm going to use a two stages alginate. So I've got a thicker alginate dense ply blueprint in the tray, and also a injectable material that just goes into the sulcus. So and it comes out beautifully like this. So and this enables me to produce a special tray, and also helps us to do a diagnostic setup. So beginning with the end in mind is absolutely crucial to these sorts of things. I took a bite record with the patient in MIP. This is Futar D bite registration material. So nicely together. This is the opposing cast. I love that. And then so we can go straight into diagnostic try-in. So just this is literally just a wax try-in. These are the study casts, the primary cast mounted like that. You can also see that Rowan's done a little bit of waxing on these canines just to improve their shape. And I can take this to the mouth. And interestingly, she loved it. It was just a little bit at a weird angle there. So that is the midline's just a little bit tilted, not quite straight, not looking. So just needed to alter that just a little bit. You can see though quite clearly as well that just changing these crowns is going to be great, isn't it? It's going to just make the whole thing look better. So we changed wanted to change the porcelain bonded to metal crowns to zirconia bonded crowns. So the next step is to get Pam in to actually to just remove these old PBCs. So I've got these stents made, silicone indexes that just sit over the crowns. You can see where Rowan's added to the teeth. This is just going to change the shape a little bit. And I can just do my temporaries really nicely. So I just conservatively just cut off the porcelain bonded to metal crowns. Just refine the preparation slightly, and get some lovely. This is honeycomb material, impression material, just of those, so that I can get Scott then to produce the PBZs. Temporize. This is with Temp Bond and Luxe Temp, shade A2, and she's good to go. This is really important. I think this is the tricky bit of doing this type of dentistry, is to put people back together, during the whole process of treating them, so that they're, good to walk out the surgery and conduct their social lives and lives normally. So 2 weeks later, I get the zirconia bonded crowns back. I like to, my ceramics technician is Scott, and he works just about 20 miles away from me. These are my written instructions, and I want them to be shaped just like the Rowan's wax up, and I'd like receipts on the teeth there. So what I did with the study cast was to just drill in some little receipts on there so you could copy that. So these are the crowns here. You can see that we've got nice, lovely dimples where the metalwork is going to sit into those, hold those teeth together, stop them from drifting further out, and just also support the denture, beautifully. And they're made to fit up against the diagnostic try-in. So this is the wax up, diagnostic wax up, and these are the final crowns there. So not exactly the same as the wax up here. That's just tilted out just a little bit. I do find it's quite difficult to find technicians that really can absolutely copy a diagnostic appliance or diagnostic wax up. So this just tilting out a little bit, it's just slightly splayed. I wasn't totally super cool about that, but I went ahead with that. And again, this is interesting, isn't it? I went ahead just purely because we've got Australia coming up, this trip away. So I'm happy just to let it go. Try them in, make sure she's happy, and then go with it. So these are the crowns fitted. You can see the lovely dimples there. And that's it in intercuspal position. So she's in a lovely, stable intercuspal position there. Make sure, I think what's super, super important when I'm making partial dentures is that the bite's nice and stable with or without the denture, because sometimes the patient may be without the denture. So I don't want like one tooth or maybe two teeth just getting totally hammered. So, Toby's asked me a question about, do I have any concerns with the porcelain fracturing off the zirconia crowns? Not, Tobe, I have absolutely, seriously no problems whatsoever. These are monolithic zirconia, so the inside, the biting surface, the lingual surface is pure zirconia, and then the outside is veneering porcelain. And I have to confess that I've been using these for 18 years, and I have very, very little chipping of the ceramic. In fact, they are miles better than any porcelain bonded to metal crowns that I've ever done, um, which is a great advantage, Tobe. The other massive advantage to this, and this is where Scott, my ceramist, is so good, he's brilliant at matching the zirconia to the he's absolutely fantastic. Sorry, my phone buzzing. It's matching artificial teeth, the Enigma Life prosthetic teeth, and the ceramic, and that's really important too with doing these combination cases. So, great question, Tobe. You don't need to shut up. It's fine. I love these questions. It really helps to clarify exactly what I'm doing. So this is my primary cast here. Can you see where I've cut in these rests there? That was just to show my ceramist what I wanted the rest seats to look like. I think they really need to have it physically there rather than just being told what to do. So I fitted the crowns and then I did my working impression here. So this is a custom tray. I've used green stick just to hold it away from the palate so I can get a really good impression of the palate whilst the teeth are literally sitting in air. And then the alginate's going to surround them. Very important. Perforated around the teeth too. So I mix up a medium mix of alginate and then I glaze it so it's lovely and smooth with running water. And I love alginate for chromes. I love it. And they're dimensionally stable for a good few days, even in the post. Fantastic. And the reason why I love them is I can do this with it. I can dry off the teeth. I can then get some on my finger and rub it into all of the occlusal surfaces of the teeth, into all my rest seats, and it just eliminates air bubbles in that area. And then I can then take my tray, rotate it in, seat it up, and I'm going to push it down onto the green stick stop, right up onto the palate, and gently coax it up into the sulcus right there. And I want to just move the frenum. Imagine the frenum's getting moved around during function. That's really good. Great. And then just let that set. I have a stopwatch going and I leave it in for a good, it takes 4 minutes to fully set. That's really important there. And it looks like this. I've got full depth of the sulcus. The denture's not going to go right up to here. With partial dentures, the flange is often a little bit shorter of the sulcus depth, um, just because we've got the alveolar process of the other teeth, and the flange is not, it's not as important, fully extended as with complete dentures. So that's the impression. I've got all of the detail of these rest seats in there beautifully. I do have a little bit of an air blow just here and here, just underneath the base of the nose, but that's not a problem. I'll just show you why that is not an issue. I'm not going to retake that. But this is the working cast that we generated, and you can see how lovely we've got all of those. We've got the rest seats gorgeously incorporated into that. And then if we look at from the front there, this is my working cast. I've got plenty of scope for the flange to go as high as possible. So these little air blows are not a problem to me. Get a bite record, Futar D, and so this is everything ready to go through to the lab. So my Rowan works in the room next door to me, but last year he was not, he wasn't well actually for 6 months. So I used to send this down to Sam down in Bolton via post, and it all, and the casting is still fitted beautifully as long as I package them up perfectly too. So that's why I love alginate for it. By the way, the time's 10 to 8 at the moment. Um, my wife Rachel's had to nip out for a bit of an emergency with her mum and dad, and we've got an electrician arriving at home at about 8:15. So when he comes in, Fred, our dog, will bark like mad. So I apologise for that. I'm just warning you in advance. You might hear this dog barking in the background. So anyway, this goes through to the lab, and then 2 weeks later, Rowan makes me the partial denture. RPD means removable partial denture. So the partial denture mock-up in Duralay resin. And I love these because they're very similar to the end product without the metalwork being done. And these are really crucial. I love doing these before we make the metalwork because I can verify exactly where the teeth are going to go, and then the metal framework can be made to fit into where those teeth are going to go. It's so important. This is like prosthodontically driven tooth positioning for the metal framework. So it's beginning with the end in mind, just like we do with implants. When I like to know where the implants are going to go, and I want to know exactly where the teeth are going to go before the implants are put in, so that the implants can be placed in just the right place to give us the best chance of restoring the patient. And it's no different with a chrome denture with the metalwork for the chrome. That's great. Hi, John. Nice to hear you're here. So maybe say something about your lip retractors. So I will do. I'll just nip back to this. So when I'm doing my impressions, Rowan, Claire puts in these little retractors and just lifts the lip out the way. And that just enables me to get the impression in beautifully. I love them, so it just lifts everything up and I can see what I'm doing. And we've made these lip retractors just from old photographic retractors, just trimmed them up. So it's a great tip, is that, John? So today, if you're in work today and you've got some spare photographic retractors, you can just trim them up and they're fantastic. Let's fast forward now to the crowns. Right, Toby has put down, is that trim on the try-in? Hive have been doing this printed for me, but really only just beginning on this journey, so feels weird. Yes, so now I know that Sam does, and also Hive are doing this printed. And so this is in its infancy, doing a printed try-in framework. But I do think that will be the future, and they'll be quite good. So that's something that you can try. But I do think these mock-ups are brilliant for lots of reasons. I think rehearsals are really key to everything. So this is the try-in in place. Just look at how fantastic that looks. Look at Rowan's wax gum work there. What I can do is, and this is really importantly, I'm opening the bite up with this partial denture. So I've jacked the patient open, palm open here. They're on the denture all the way round and right onto the back teeth. So just opened her up in that intercuspal position there. And it's fantastic. So she can assess this and make sure she's totally happy with the look of it there. And also, I can assess it's fitting properly. So it gives me a good feeling about the fit of how the chrome's going to fit too. I can assess the occlusion and then she can really inspect it in the mirror. And what I love doing at these visits is just doing a nice video of the patient too. And this is a still photograph of the video, and it means that Pam can have a good look at it and assess it. And she loved it. It was just great. So from that point now, I can then go to the next stage, which is go to the metal-based try-in. So the mock-up here, you can see the resin mock-up there, is identical to the try-in. So even the mouth feel of these mock-ups is really quite, it's not just the same, it's not quite as smooth, but it's getting there and it gives the patient a good idea of how it will feel in terms of support. It also enables me to assess the phonetics too. The speech is super important. So now we'll fast forward to the metalwork, and you can see how having this try-in like that, the teeth are going to be the metalwork is engineered to fit where the teeth are going to go. And then I take this to the mouth and just check it in the mouth before we finish. Just a little word about clasping. Now, do you know what I really hate? Is I really hate cast cobalt chrome clasps. I hate bending them because they're so stiff. And if I try to tighten them, often what happens is I deform the way it fits around the tooth at the back here. So I can actually make a well-fitting denture that maybe is a little bit loose, and not fit properly. So I've found the best way to improve retention if these are a little bit slack is just popping a little bit of a composite button just here to help with that. Now what I'm doing instead though with my new partial dentures like I did for Pam is I'm using wrought cobalt chrome clasps here which are welded to the framework. And these wrought clasps are lovely because I can bend them. They're more flexible and they bend more easily, so I can tighten them without being concerned about this bit not fitting properly too. So these are the frameworks here on the working cast there. And you can see how we've designed it with these struts so that when the acrylic teeth are bonded on there, they're going to be really, really strong. Look at the metal framework from the side here. I just thought this was a super interesting photograph. Look at how high the pallet is, how it sweeps up. It's like a ski jump, isn't it? Down here, really steep. But I want that to fit intimately onto the pallet so that we get maximum support from that denture too. It's really, really lovely. So, Toby has asked a really great question. You're on it today, Tobe. You've asked how much extra work is involved for the lab and hence increased cost. A lot, Toby. For these, uh, they cost me at least between 50 and £100 per denture, per clasp, per denture. So we've got two on here. That's an extra £200 on top of the lab fee, which is around about 300. So for the chrome framework, it's £500, Tobe. So it's a lot of extra work. So if you're reluctant to do them, and understandably, I know that might be outside of patients' budgets, a cast chrome clasp at the back there, but make sure you put your composite button on the side of the tooth there to make sure it's really nicely retentive. So it's really good. Hi, Gian. Gian, you've asked a super question. Have you ever gold plated the chrome instead of opaque? Um, so just at the front here, yeah, actually, I no, I haven't plated the chrome before because well, I have actually. Yeah, I'm talking nonsense here, Jan. I have done it, but it does rub off, so it's it's better. I just leave it. But you can actually just sandblast these surfaces just to help to just make them shine a little bit less. But it's a good question. So Toba said, yes, those fees are pretty punchy. But I'm still a generalist, so they are a bit punchy, you're right. So this is ultra high end. So, but great. Lovely question. So this is the try-in here. Now, what I want to see is the whole thing fitting beautifully with no gaps. And I just want to share with you a little tip that Rowan shared with me years ago on making these things fit really well. So if I'm trying a chrome, and by the way, this is not Pam's chrome, I've just pulled this from another case just quickly, is what I do is I spray occlude this powder spray onto all of the fitting surfaces. I make sure it's totally dry, spray it on, I then take it to the mouth and then rock it in there. And then I take it out. And if it's not fully seating, I look at certain areas. So I want to focus your mind on the these areas here. Can you see that around there? So what I'll do is I'll take a drill. This is a burr, which is a chamfer crown prep burr, and I grind off these areas where it's rubbed away. You can also see it just here, just here, just there, just there. So little bits, just touching those little bits. Now, but I want to just really emphasize, really importantly, I very, very rarely touch this edge position here. I don't want to touch that because if I do, I can create gaps forming between where this edge of the chrome fits against the tooth. I do not want to create a little gap or a divot where food's going to collect. So I'm quite comfortable about adjusting underneath that edge position. So if any of you are fitting a denture today or trying a chrome in, just avoid the edge along here and just trim away underneath and the chrome will fit much better with no gaps. It's exactly the same with acrylics too. So that's great. So once I'm happy with that chrome try-in, Rowan can finish the denture with the teeth because we've already done that trying on that pattern resin trying. So we'll get the denture finished nicely there. So this is the denture there. Let's have a close up. First of all, I just want to highlight the pin position on the articulator. So this is Pam's mouth in MIP. So she's fully closed together. So the pin's at 0 there. And then with the new denture in place, we've opened the bite up on the metal at the back and the metal all the way around on the whole of the denture. So effectively, this RPD, this removable partial denture, is a occlusal stabilization splint 2, and it's made at 2 millimeters increased height. I want the minimum thickness of the metal on the back teeth to be 0.5 millimeters. Hein from New Zealand. Hi, Hein. It's great to hear from you. With the increase at the OVD, is the new occlusion purely attained by the thickness of the rests of the upper chrome cobalt framework? It is, absolutely, Hein. I'll show you just in a sec. I'll just move it through so you can have a look at the occlusal view of it. So these rests here jack the bite open as well. So the whole thing is opened up. So it's a great question, is that, Hein? So also, I just want to talk about retention. This is really, really important now. So this type of denture is called a rotational path denture. So the denture slides up on this guide surface here at the front here, and then rotates up at the back and basically just clips in at the back. So we've got two areas of retention on both sides of the denture. I've got retention from this posterior clasp here, there, and also I've got indirect retention, you can call it that. I just think it's still just retention. It's no different from this flange. So we've got retention there and there. So this, it resists chewing and sticky foods, and it from wanting to drop down with gravity too. Really important. So Deepanker has asked a super question here. Hi, Deepanker. Hi, how does Rowan manage to bond those acrylic teeth onto the framework? Just acrylic or anything else? So, yeah, it's just with acrylic, Deepanker. So he'll use metal primer and then bond on, and it just goes around, and it's really mechanical retention, Deepak, onto these areas here. Can you see these struts there? So that's like the acrylic's just going to go right the way round there. So the pink acrylic goes into that, and the teeth themselves, the artificial teeth are bonded and have little rods in too and cut into. So they also have mechanical retention too. The actual Enigma Life teeth there as well. So great question, Dipanka. Thank you. So let's fast forward back to this retention. So this is really crucial. So this is going to really help here with the way it looks too. Fantastic. This whole thing is going to look amazing at the front there too. This is all acrylic, pink acrylic work using secret acrylic tinting. Sounds like the electrician's arrived. As Fred barking. Sorry about that. John's asked me to say something about the absence of a flange on the posterior teeth. I will do. Here, look at that. Doesn't that? Now, when I have individual teeth like this on their own, it's much better, I find, aesthetically. And this is something that John Besford taught me, was just to lengthen the roots of the tooth without the pink on. You know, we often get these partial dentures with this I can only describe it as disgusting pieces of pink that just don't look like natural teeth there. So when this is in the mouth, it looks way better, and you'll see it just in a minute. So thanks, John, for that input. It's great. I love how you just putting these Q&As in here. It's lovely. So look at this here. This is the Scandinavian design. I'm trying to keep everything away from these gingival margins as much as possible. This is an artificial tooth. This sweeps right up there. It's really bombed on, and then we've got metal either side. We've got another tooth here. Look at that. No flange on that. It's going to look much better. Lovely welded clasp just on here. Everything's all protected beautifully. Looking great. There. Acrylic tinting. Shotlander Enigma Life teeth. Nicely finished. Lovely flange. No pink. JB. Looks good. Lovely. Lovely rest seat. Can you see that dimple there? I just love the looking at these pictures, how Rowan gets all the gum characterized beautifully. A little bit of um, non-attached gingiva there with veining fibers. Beautiful. Lovely fitting surface, not polished. You can see this is all anywhere that I might have adjusted, I sandblast that. So we've got a lovely retentive fit on the denture too. And these things really are not that heavy. So this is why some people like titanium frameworks, but I still love chrome because chrome actually is more rigid than titanium. So it can be made in thinner cross sections and not be bendy at all. And it's also super resistant to wear. It's lovely. So this is it fitting in the mouth. We've got this look at that junction between the natural gum and the artificial gum. This lovely thin flange. It's knife edge almost. But can you see how this artificial tooth with no pink work just looks better there? So John's asked, do you ask for no electro polishing of metal which touches the tooth surfaces? Yes, I do. So no electro polishing of the fitting surfaces. I'll go back to the fit there. So where it touches against the teeth, no electro polishing. But if I do, John, have to adjust it to make it fit, if it's just holding off and have to grind a bit off, I then just use aluminium oxide to sandblast that surface to get it nicely, almost like a nice rough finish, really. And I find that little detail helps with retention too. So it's a great tip that you gave me, John, for that too. So John's listening, John Besford is listening, who has been my mentor for the past 15 years, and I've learnt so much from him. He's amazing. So thanks, John. Right, let's have a look at it. Back into here. So this is it fitted. We've increased the vertical dimension. A lovely even occlusion on that. Look at this. This is this is to die for, isn't it? The junction between there and there. And look at that lovely length on this tooth. Just lengthening the tooth, making it look real. But also, can you just see here how much better just a single tooth like that looks than if we have that horrible bit of pink on? Really, really, really important details, these. Um, she loved it straight away, fitting it there. So this is showing the that horrible gum stripper, and then this one, which is much more robust. So this is the a splint stroke partial denture. It's great. Nice sort of change of face, slightly improved upper lip there from the old to the new. More passive, happier looking face. But this is what the patients love coming as well. It's a total social visit. The whole thing is so social. It's lovely. This is that individual tooth. You can see there, John, that it just looks so much better without horrible pink on it. And I don't mind black triangles. They're fine because people have them when they get older. We get recession. Looks better. So happier looking patient. She loves it. Nicer looking crown, better shade. That's great. Interestingly, I think what's super important is when I'm opening the bite like this and doing these metal backings, it does actually make the speech a little bit splashy, lispy. So that's something I warn the patients about. However, the longer they wear it, the more they get used to it too. So Kai has asked me a question. Hi, doctor. May I know how do you weld the clasp to the framework? So the clasp is welded using a solder. So it's a cobalt chrome solder, which then is used to weld the framework. It's quite time consuming. It's quite technique sensitive, but it's a good question. So it's a solder. It's a chrome solder. So once they're fitted, and this is um, Pam here with her sister Claire. So they both came in at the fit appointment, and I like to sit down and have a really good chat with them round the table, not in the chair after I fitted it and what to expect. So I'm talking about, chewing and eating, potentially lip biting, problems that may happen, maybe some soreness, um, increased saliva flow can happen, these sorts of things too. That's really good. So Daniel Peterson, hi Daniel, has asked me a question. If my final denture results in a slight open bite, what have I done wrong? Well, Daniel, if the denture does result in an open bite and you've not planned it, it can be a number of factors, but quite often it can be just rest seats. I quite often find that rest seats can just jack the bite open. So if Daniel, I'm wanting to make a denture that where we're keeping and maintaining the same intercuspal position. So the maximum intercuspation positions, we're keeping it the same at the same vertical. And I want the new denture to be just the same with or without the denture in place. If when I fit it, sometimes it may jack the bite a little bit. And sometimes what it can be is that the lower teeth have erupted into my prepared rest seat. So what I'll often do is I'll just preferentially just adjust the lower cusp just to adjust it so that it then makes the bite nice and even. So I'll just round off the opposing cusp a little bit. But it can be lots of reasons, Daniel, but often it is jacking open on a rest seat. Great question. Now, also with these patients, sometimes they'll wear this denture at night if they want to protect their remaining teeth, but also I do give them a soft night guard too. And the soft night guard is 3 millimeters thick. It jacks the bite open like that, there. So they can just pop that in and wear that at night. I don't do hard bite splints just because I find that the patients don't really like them as much. But it may be just the way that I make them. Maybe I'm not as good as some people at making hard bite splints. So I just find this works nicely. And then I do like them to have them replaced every year because they can just wear out. And this is really to protect the remaining teeth from nighttime grinding. So that's it there. So let's just think about this case. Now, I want to just go back now to newsletter 73. And you know what? I showed this case, Keith's denture, and I made a big mistake with Keith's denture here, where we used these little backings as opposed to like Pam's denture, where we've got full metal backings like that there. And do you know what happened to Keith? He loved his denture. It was really comfortable, but sadly, it fractured. So all that front bit here broke off like that there. So I've repaired it, we've refitted it, and it's working okay. But with Keith, sorry about the spelling, I've just put G there. But with Keith's denture, he wasn't cross about it at all, and he's a nice guy, which is I think really important. I've made him a spare acrylic denture now that he can wear just in case this fractures in the future. So, but if it keeps doing it, I'm just going to replace it with a metal-based one, just like we've done for Pam. So I'm hoping that Pam's doesn't do that. But what's really important though is that sometimes people can reach these incised ledges and just flick off even prise the edges off. But I'm just hoping that, that's not going to be the case for her. Anyway, I saw her for one review, and the nice thing about these really well supported, they're almost like semi-permanent splints. That's what Charlotte Stillwell calls them, where they are just so well supported. They're like bridges. I only needed to see her for a review. It really did change her life. She loved it. And you know what? She brought in this massive picture, which I've just got. I'm in my office here at the moment. I've just got it on the wall here. It's huge. And she's painted that for me. And it's just so touching when patients are so delighted. And I think it's such a privilege, really, changing people's lives. I love it. And that's why it's such a real privilege to do this job too. And we've got an opportunity to do that for our patients. It's just wonderful. And they're just dentures. It's not implant work. If you're interested in learning a bit more about how to do this, my next partial denture course is next month at the end of February. And I do have quite a number of spaces available. So if you want to come in to do this, then that'll be wonderful. Because I've got this is Angela, who is my demonstration patient. These are Angela's dentures, and I go through from start to finish, how we actually treat Angela, and it's wonderful. You can really look at these sorts of things too. My 2026 cases are all open for bookings now. I'm running 7 different courses next year on all types of dentures, and I'll be around and about doing different speaking engagements. I'm actually in Watford tomorrow, doing a full day tomorrow. Next week, I'm doing a webinar for the European Academy of Aesthetic Dentistry. I'm super excited about that because that is a super high-end group of people, and I can't wait to promote dentures for that. I'm going to be in Amsterdam in December the 12th, for speaking at the Dutch Implant Society with a lot of other British speakers who are brilliant at what they do. These are some fantastic speakers, so I'm super excited about that. I'll be in America twice next year too. I'm going to be at the Seattle Study Club in January, and then I'm doing a full day in Dallas, Texas with Rowan. He's going to come with me too. And then during the year, I'm going to be doing 2 separate days, one in London and one in Birmingham. These are full days, and I'm going to be presenting my failures. I'm a bit nervous about that, but every single case will be something that has gone wrong and how I got out of it. So it's going to be like I'm going to be opening my heart to you there too. So that's great. And then if any of you would like to just discuss cases, I'm open for mentoring too. That's really good. I'll see you next month, November the 13th, for my next study club. So look out for my newsletter, which will be before the next study club. This is all recorded for you to live. So I'm going to upload this to YouTube just in a second. Thanks very much.